Our last topic for lecture unit 1 is going to be our joints, also known as articulations. You'll find this content in chapter 9. So an articulation or a joint is described as a meeting of two bones, but it could be potentially bone to cartilage, or even your teeth in the bony sockets that they live in of the maxilla and the mandible. Those are all examples of articulations. A lot of the words that we're going to be seeing in this chapter are going to use the root word arthro. Arthro translates to joint. It's a Greek root word. You've probably heard of arthritis, which is inflammation of the joints. But we'll see that the structural anatomy of joints will also incorporate this word arthro. Structures of joints, so the materials that they're made of, the things that are holding the bones together, the bones to cartilage, are generally there to be able to be functional. And so the function of joints is sometimes to move, but in other cases, we want joints to not be able to move, such as the joints of your skull, for example. We want those joints to remain stable and immovable. And the structure is going to enable the joints to be able to resist any sort of crushing or tearing or pulling forces, and for that joint to be able to do its job of either moving, slightly moving, or being completely immovable. We can classify joints both structurally and functionally. We're going to focus on the anatomy, that's the structural classification, but for each of those, we're also going to take a quick look at the functional classification. Function of a joint is really how much movement is allowed. So the functional classification comes in 3 categories. Some joints in our bodies are completely immovable. This would be the meeting of two bones, like the flat bones of the skull, for example, your lambdoidal suture or your sagittal suture. Those are all examples of immovable joints. We want those bones to be held together tightly and carefully without moving. That's described as a synarthrotic joint or a synarthrosis. Really common in your axial skeleton. Amphi is kind of partly, a little bit. So amphiarthrotic joints are going to be slightly movable joints. These are also more common in the axial skeleton than in the appendicular skeleton. An example of a slightly movable joint would be the joint between two of your stacked vertebrae. Now, the entire vertebral column is 24 stacked vertebrae, but a single joint exists between each set of 2 vertebrae, one stacked on top of the other. You might think that, oh, well, I can bend my back, right? Maybe you can reach down and touch your toes. Well, that's actually due to the action, the combined action of all of those amphiarthrotic joints, kind of slightly moving, one on top of another, that enables us to get those curves to be able to maybe go touch our toes, or maybe you can do like a back bend, right? But again, that's the combined action of all of those amphiarthrotic joints. Every single one of those individual joints is only slightly movable. And then finally, we have diarthrotic joints. Those are the freely movable joints of our bodies common in your arms and in your legs, also known as the appendicular skeleton. We're going to see that the degree of movement might vary. The shoulder, for example, is extremely movable. It's a multi-axial joint. It can move around in all axes, versus a joint like the elbow, which is just a uniaxial joint, really, just can move in this anterior and posterior direction by basically bending and straightening. So the degree of movement might be different, but diarthroses are considered freely movable joints. We're going to focus on the structural classification of joints for the anatomy part of our articulation lecture. Structural classifications are based on what's present that's holding the bones together, holding the materials together, whether or not there's a joint cavity, which is a fluid-filled capsule that surrounds the articulating surfaces of these bones. So structural classifications come in 3 broad umbrella categories. Fibrous and cartilaginous joints are going to not have a joint cavity. So if there's no joint cavity, then we're going to find that it's either a fibrous joint or a cartilaginous joint. And to define these, we're going to turn to the materials. So no joint cavity, the main connecting material is fibrous connective tissue. That's a fibrous joint. No joint cavity and the main connecting material is cartilage, then we define that as a cartilaginous joint. If there is a joint cavity, a fluid-filled capsule surrounding the articulating surfaces, all joints with a joint cavity will always be classified as a synovial joint structurally. Synovial joints always have joint cavities. Now, synovial joints may also have cartilage or may also have fibrous connective tissue, but they're always classified as a synovial joint based on the presence of a joint cavity. Doesn't matter what else is there holding the articulating surfaces together. So let's go ahead and start with our fibrous joints. In a fibrous joint, there's no joint cavity, no fluid-filled capsule surrounding the articulating surfaces, and your bones are going to be connected by fibrous connective tissue proper. This is really going to be dense, regular connective tissue. So remember, dense, regular connective tissue has lots of collagen fibers all running parallel, those ropes of collagen, so it's really strong, really resistant to pulling forces in the same direction as those collagen fibers are running. Most of these fibrous joints are going to be immovable or synarthrotic. Some of them may be slightly movable or amphiarthrotic. The degree of movement, whether it's synarthrotic or amphiarthrotic, is generally going to be related to the length of the ligament, the length of this dense, regular connective tissue that's connecting the bones together. The longer the ligament, the more movement is allowed. Shorter ligaments are going to be associated with less movement. There are 3 types of fibrous joints. We have sutures, common in the flat bones of the skull. We have a syndesmosis, and we have a gomphosis joint. The next slides will go through each of them. Sutures are these jagged, wavy joints between the flat bones of the skull. These are all considered synarthrotic, immovable joints. So all of the bones of the skull are connected together through sutures. There are a couple sutures that are on your hit list for Lab Unit 1, but there are many more sutures of the skull than just the ones on your hit list. All of these connections between our flat bones of the skull are considered sutures. What these sutures do is they allow the bones to continue to grow so that growth of the skull can happen, growth of the facial bones can happen during childhood. And the sutures, by having these interlocking lines, also prevent the bones from shifting adjacent to one another. So it really tends to hold those 2 bones together nicely locked in place, providing a nice protection for the brain primarily and the sensory organs of your skull. So that's the sutures. You would see in a living skull, you would see a thin line of dense, regular connective tissue. We call that a ligament sheath located between the interlocking connections of these neighboring bones at the position of a suture. The next fibrous joint is a syndesmosis joint. Syndesmoses are going to be classified or characterized by having essentially longer strips of dense, regular connective tissue connecting the articulating surfaces. Again, a syndesmosis joint is a fibrous joint, so there is not going to be any sort of fluid-filled capsule surrounding the articulating surfaces. These essentially ligaments that are connecting the bones together can range in terms of their functional classification. One example of a syndesmosis is the interosseous membrane between your radius and your ulna of your forearm or antebrachial region. Now, your elbow is a freely movable joint and your wrist is a freely movable joint, but these 2 bones can rotate around one another. And that rotation, that slight movement that's allowed between the bones can be experienced. If you're standing in anatomical position with your palms facing forward, try holding your arms straight and flipping your palms so that they're just facing backwards. Your shoulder didn't move, your elbow didn't move. What you just did was twisted your forearm. That twisting kind of crisscrosses these bones, and that is a slight movement between these two bones that you just did. So that kind of movement is considered amphiarthrotic movement. There's another interosseous membrane between the tibia and the fibula of the lower leg that allows for a slight bit of movement between those two bones as well. So the functional classification of amphiarthrosis is the most movement that could be allowed by a syndesmosis joint. There is another joint, it's the distal tibiofibular joint. If we look back at this image here, this joint between the tibia and the fibula, so tibia is the big bone at your ankle or lower leg really, and the fibula is the small bone on the lateral side of your lower leg. This joint here, not the ankle, but this joint between the tibia and the fibula is connected by a small strip of dense regular connective tissue, and this joint does not move. So the bulge that you're seeing right here of the fibula, it's called the lateral malleolus. That is your outer ankle bump. So you know your ankle, there's a bump on the inside and a bump on the outside. This is that lateral bump of the ankle, and that guy never moves. It should not move adjacent to the tibia bone. And so that's because we have this syndesmosis. In this case, this really short ligament is creating a synarthrotic joint here. So it's completely immovable. All right, so some syndesmosis joints are going to be amphiarthrotic. Other syndesmosis joints with smaller, shorter ligaments are going to be classified as synarthrotic, immovable joints. The last fibrous joint is a gomphosis. This is a special joint between the tooth and its bony socket. So this is not bone to bone. Tooth is made of a material called dentin, and so it's a different material altogether. When the tooth sits in the bony socket of the alveolar process, we're going to see that the walls of the alveolar process surrounding the tooth, they're called the interalveolar septa. So that's a wall between two tooth sockets. The interalveolar septa are connected to the tooth via a sheath of a ligament called the periodontal ligament. That periodontal ligament anchors the tooth in place. This gomphosis joint is typically classified as a synarthrotic joint. Of course, when teeth fall out, this joint does actually change, but during a normal healthy tooth positioned in its socket, we would classify this joint as a synarthrotic immovable joint, the gomphosis joint. The cartilaginous joints, again, are going to be the second anatomical classification or structural classification of joints, and there are two specific types of cartilaginous joints. These guys are actually classified or distinguished based on the type of cartilage that's connecting the articulating surfaces together. Just like fibrous joints, cartilaginous joints never have a fluid-filled joint cavity surrounding the articulating surfaces, and the articulating surfaces are mainly connected by cartilage. When that cartilage is hyaline cartilage, we call the joint a synchondrosis joint. When the cartilage is fibrocartilage, we call the joint a symphysis joint. So synchondrosis joints, again, hyaline cartilage is the main connecting material. An example of a synchondrosis joint is actually at the epiphyseal growth plate located at both the proximal epiphysis and at the distal epiphysis of every single long bone in a child. That is considered a synchondrosis joint. If you think about this epiphyseal growth plate, it is connecting the bony epiphysis to the bony diaphysis. So a synchondrosis joint, hyaline cartilage is the main connecting material. The functional classification of this joint would then be immovable. It is a synarthrotic joint. If you take a look at the rib cage, you'll see more examples of synchondrosis joints. Your rib cage is kind of interesting because it does move. These ribs are going to all elevate. They all raise up every time we inhale, and then they all settle back down. They depress every time we exhale. The movable joint that's responsible for the elevation and depression of every single rib is actually the joint located adjacent to the sternum. The immovable joint that's considered a synchondrosis joint is this joint here. We're going to find that every costochondral joint, so rib to its costal cartilage, rib to its costal cartilage, rib to its costal cartilage, those are the examples of synchondrosis joints that we have here in the rib cage wall. This is a synchondrosis, this is a synchondrosis, this is a synchondrosis. And then it also turns out that the joint between rib number 1 and the manubrium of the sternum, that whole thing, is a synchondrosis joint. Your first rib does not move. It doesn't elevate and fall. But all these other ribs, they do. They elevate and fall, right? These ribs, they raise up and then they depress back down with every time we inhale and every time we exhale. And that's because this joint here, adjacent to the sternum, is a synovial joint. This is a diarthrotic joint, allowing the ribs to elevate and depress, raise and fall every time we breathe. Symphysis joints are cartilaginous joints with no fluid-filled joint cavity, no fluid-filled capsule surrounding the articulating surface, and in this case, the main connecting cartilage is fibrocartilage. These symphysis joints are really, really strong because of that fibrocartilage. All the collagen and the packing of chondroitin sulfate ground substance, these joints are able to resist extreme tension or pulling forces and extreme compression or pushing forces. So we find symphysis joints located between our vertebrae. Every single intervertebral disc has a huge chunk of fibrocartilage at its core, and that's going to serve as a joint located between two bones, between two vertebrae, separating the bodies of the vertebrae from one another and connecting them to each other. So those intervertebral discs are examples of symphysis joints. The pubic symphysis, this is the one that's located at the anterior part of your pelvic girdle. That pubic symphysis is also a pad of fibrocartilage connecting the left os coxa to the right os coxa anteriorly. That pubic symphysis is an example of a symphysis joint. All symphysis joints are slightly movable amphiarthrotic joints. Note here that there is fibrocartilage. You've already learned that there is fibrocartilage in the meniscus of the knee. However, the knee is surrounded by a fluid-filled joint capsule. So even though there's fibrocartilage within that joint, it is not considered a symphysis joint because any joint with a fluid-filled capsule will always be classified as a synovial joint. The knee, the elbow, the shoulder, the hip, the joints of your fingers, all your knuckles, your wrists, these are all considered synovial joints. So we'll talk about these guys in the next screencast.